I'm Rani Chatterjee. I'm an associate professor in the Division of General Internal Medicine, and I'm going to talk to you about diabetes prevention and specifically 2 micronutrients that may play a role. Here are my disclosures. So as you all know, diabetes is a huge problem in the United States. The incidence and prevalence have doubled since the 1980s, and diabetes affects certain race groups more than others, particularly Native Americans, African Americans, and Hispanics. What's of particular interest to me, though, is that over a third of American adults have a condition called prediabetes, which really ranges from people who have sugars that are just above normal all the way to people who are almost with diabetes level glucoses. But if we can identify this condition of prediabetes, there are things we can do to help prevent progression. And that was shown in the DPP program, or the Diabetes Prevention Program, which was published in 2002, which randomized people who are in that mid-spectrum of prediabetes to an intensive lifestyle intervention, metformin, or placebo. And what they found is that people who were randomized to the lifestyle intervention had a 58% reduction in their risk of diabetes, and people in the metformin arm had a 31% reduction in their risk of diabetes. Other clinical trials looked at this and tested lifestyle interventions, and taken together in this meta-analysis that was done, they found that intensive lifestyle interventions can reduce risk of progression to diabetes by about 47%. So what do I tell my patients with prediabetes when I see so many of them in clinic? Well, I can tell them that intensive lifestyle interventions can reduce their risk of diabetes, but that in order to be effective, they really need to lose 7% of their body weight, and they need to do that through exercise and diet. The diet that the DPP used focused on fat and calorie intake, so it wasn't very prescriptive. But I can't get them in a clinical trial, so I can refer them to DPP programs in the community that are offered through churches and YMCAs. But unfortunately, these DPP programs aren't as effective as the clinical trials were. And so effectiveness ranges from diabetes risk reduction of 5% or less to 24%. I can offer them metformin, but a lot of times patients don't want to take that, especially at the beginning of their diagnosis. And so are there other recommendations that can help? Ideally, for diabetes prevention, we would have simple and sustainable interventions that can be applied broadly at the public health level and that would complement these other lifestyle changes that, of course, I would encourage my patients to make. And so that's where I'm interested in finding out whether vitamins and nutrients can play a role. So there's been great interest in vitamin D for its effect on many chronic conditions, including diabetes. And in the clinical research spectrum, we start looking at this association with analyses of longitudinal cohort studies. And so this is a meta-analysis of cohort studies, which found that compared to people who are deficient in vitamin D, as defined by a serum vitamin D less than 12, those who had higher vitamin D levels had a 35% reduction in their diabetes risk. Mechanistic studies were done to tease this out a little bit more, such as this one, which randomized 92 participants with prediabetes to 2,000 international units of vitamin D versus placebo. And they found that over a 16-week period, their pancreatic beta cell function improved in the vitamin D arm compared to placebo, and that their overall sugar control over the 16-week period, as measured by change in A1C, worsened a little bit less. And so this evidence, along with the observational studies, led to the funding of a multi-site trial funded by the NIH. It was led by Tufts University, and the PI was Tazo Pittas, but our Duke Primary Care Research Consortium was a site. And this study was designed to test whether or not vitamin D at a dose of 4,000 international units a day versus placebo reduced the risk of progression from prediabetes to diabetes. So participants had to have prediabetes at baseline and were overweight and obese. And the sample size of this trial was designed so that we could detect a 25% risk reduction in diabetes. To do that, we recruited about 2,400 participants. We had 140 participants here at Duke. These are selected baseline characteristics of the participants. So the mean age was about 60. There were about 24% African-American participants, 9% Hispanics. Participants had to meet 2 out of the 3 criteria for prediabetes in order to be eligible for the study. What was not an eligibility criteria, however, was the serum vitamin D level at baseline. And we actually ran those samples at the end of the study and found that it ended up that about 80% of the cohort was considered sufficient based on National Academy of Medicine criteria A small percentage were considered deficient, and the mean level of serum vitamin D was about 28. So safety was an outcome of interest for this study because this dose of vitamin D, 4,000 international units a day, had not been studied in a large trial before, and it's considered to be the National Academy of Medicine's recommended tolerable upper intake level. So on the high side of what's recommended for daily use. So safety was an outcome of interest, and we found that this dose was safe. So there were no significant differences in kidney stones, hypercalcemia, or hypercalciuria over about 3 years of follow-up. As far as the primary outcome goes, we did find a lower event rate of diabetes in the vitamin D arm with 9.4 events per 100 person years compared to placebo, which had 10.7 events per 100 person years, but that was not statistically significant. When we looked at certain subgroups, we found, though, that among the small percentage of participants who were truly vitamin D deficient at baseline, based on their serum vitamin D level of less than 12, they seemed to really benefit from vitamin D. So this top blue line on the left shows their survival-free period from diabetes. And so for the people who were randomized to vitamin D in this deficient group, they had a 62% reduction in their diabetes risk, which was not seen in the participants who had higher vitamin D levels at the beginning. So in all, the D2D study showed us that in American adults with prediabetes not selected for vitamin D insufficiency, a dose of vitamin D at 4,000 international units a day did not significantly reduce the risk of progression to diabetes, but we did find that it was safe and that it might benefit certain subgroups over that period, such as people who are vitamin D deficient. Since publication of that trial last year, meta-analysis has been done with other trials that looked at the effect of vitamin D on diabetes risk. And taken together, it seems that vitamin D at a dose of 1,000 units a day may help reduce, or does seem to help reduction of diabetes risk, but by 12% and not by the 25% that was estimated for the D2D study. So the second nutrient of interest, whose evidence isn't quite as far along, but is of interest to me, is potassium and diabetes risk. And so as we all know, potassium is hugely important for cellular processes. Serum potassium levels tend to be very tightly regulated with a range of 3.5 to about 5.5. We check it in clinic all the time, but what we don't measure in clinic is total body stores of potassium. And so that can only be measured with radioactively labeled potassium and total body counters, which just can't be done in clinic. But it has been found that serum potassium levels in that low range, so 3.5 to 4 or so, can reflect total body stores. And the prevalence of low total body stores of potassium is pretty feasible in America because typically the Western diet is very low in potassium. And so less than 3% of Americans achieve the adequate intake of potassium, which is deemed to be 4,700 milligrams a day by the National Academy of Medicine. And that was based on known health effects of potassium. So we know that potassium does affect blood pressure, and that's been proven in clinical trials. And in observational cohort studies, it seems that potassium levels are associated with stroke risk, cardiovascular disease risk, and mortality. The associations between potassium and diabetes risk was initially recognized through indirect associations, but I was interested in that and first started studying that by analyzing an observational prospective cohort study as a clinical research fellow at Hopkins. And we looked at the ERIC cohort at first, which is a cohort of about 16,000 American adults. And this analysis looked at their diabetes risk over a 9-year period and found that compared to people with a high normal potassium level, so about 5 or a little bit higher, those with a potassium level that was still in the normal range, but lower than 5, had a higher risk of higher risk of diabetes. And that was true adjusted for all the typical diabetes risk factors. There's a known racial difference in potassium's effect on blood pressure. And so I was interested to see whether or not there was a racial difference in the potential effect of potassium on diabetes risk. And so we looked at that in this cohort as well. And we found that at baseline, serum potassium levels did differ by race. And so the potassium levels of white participants were higher, as indicated by these white bars, compared to the African American participants. whose serum potassium levels are represented in the dark bars. And when we stratified our main results by race, we did not find a statistically significant interaction by race, but we found that while both whites and African American participants' diabetes risk increased with lower potassium levels, it seemed like the African Americans' risk was greater. So I looked at a lot of different observational cohort studies to try to tease this out more, and thankfully somebody else did a meta-analysis of these cohort studies and found that for every 1 millimolar per liter increase in serum potassium level, diabetes risk could decrease by about 17%. And my interest in potassium is stemmed partly because I think it's interesting, but mostly because I feel like it could be a modifiable risk factor. And so with the support of a KL2 at Duke, we were able to test this in a pilot trial, which the purpose of which was to test the feasibility of doing such a trial and to get some preliminary effects of potassium supplements on measures of glucose metabolism. So we randomized 29 African American adult participants with prediabetes, defined only by A1C, a low normal serum potassium, and we randomized them to potassium supplements at a dose of 20 milliequivalents twice a day or placebo taken for 12 weeks. We found that they did take the intervention well, and I'd been worried about that because if anybody knows what potassium chloride tablets look like, they're pretty big, but there was 92% adherence. They all gained some weight during the 12-week period, but those in the potassium supplement arm, their potassium levels did increase, although maybe not as much as I would have thought. And as far as our outcomes go, we did find that there was a statistically significant difference in fasting glucose. So the people in the potassium arm had a slight improvement in their fasting glucose. They also seem to have some evidence or trends of improvements in insulin sensitivity. And with that finding, we followed it up with running a targeted metabolomic assay on stored serum samples, and we did that pretty recently, and found that those in the potassium supplement arm had an improvement in their branched chain amino acids, which is a metabolite that's strongly associated with insulin resistance, cardiovascular disease risk, and diabetes risk. So our conclusions from the pilot trial is that potassium supplementation is well tolerated. The dose we tested was associated with a small increase in serum potassium levels, but that even at that small dose, we saw some improvements, although minor, in fasting glucose. We saw some trends in improvement in insulin sensitivity and branched chain amino acids, and I feel like this deserves further study, probably with higher doses of potassium. So with all this background, what do I tell my patients now? Well, I still tell them that lifestyle interventions is the main way we can prevent diabetes, but I am more cognizant of nutritional deficiencies and the need to address those if they're present. I think further study is needed to help test nutritional interventions. And then I still think that, when these efforts fail, metformin is a viable option for diabetes prevention. And so I want to thank all my mentors and my collaborators and all the great teams that I get to work with. And thank you for your attention.
Thank you so much, Dr. Chatterjee. And thanks to all of our speakers. What a phenomenal job and a real great showing of the spectrum of the phenomenal work that goes on here at Duke. We do have some time for questions. And so just to let folks know, we have a Q&A box that everyone can use if they have questions. I'm going to go in order here. With the first question actually going to Dr. Zimmerman. So Dr. Zimmerman, I thought your data where you looked at enrollment and racial and ethnic bias in the PTN enrollment, really finding that in fact in the PTN, you're doing a good job of appropriately representing our community populations in your studies. I'm going to assume, this is clearly not what we see in adult trials. I'm going to assume that there's something unique here about the PTN, and I wondered if you had any thoughts on that.
Sure. I don't know if there's anything unique or what exactly that is, but I'm certainly happy to speculate on and to tell you about the things that we do that might be helpful. One of the things is that we have an open network. So for every trial, basically any place that wants to participate is potentially eligible to participate. So you can participate in one trial, you can participate in 10 trials, you can participate in no trials. So I think that flexibility allows us to kind of travel around geography for people to match the disease state to their population. So I think that's potentially one thing. A second thing is that we have really a capitated payment system. So there you are, you get paid for enrolling patients. So it is to your benefit to approach every single patient you possibly can and enroll every single patient that you possibly can. And I think potentially the third thing is that we really have an emphasis on training and a mentorship type of program, even at the sites, the local sites that are doing enrollment. So there is possibility that you have, a senior mentor who is the PI, but also a junior person who is the sub-I, which gives, I think, a lot of opportunity for variety in types of people and racial, ethnic distribution of the people who are enrolling within our studies. And then finally, I think our CRAs are remarkable and do a really amazing job helping people to brainstorm. They connect very closely with study coordinators and giving them ideas about how to approach people and what to do. So those are just some of the reasons that perhaps have been beneficial for our studies.
Yeah, well, congratulations. I think it's great. It's great to see, and something that we all strive for, obviously, in our clinical trials. So great work. So the next question is going to be for Dr. Bojorquez, and this is in the Q&A box. So this question is from Carolyn Diaz, and it says, I was wondering if you see the same behavioral effect, increased consumption, with other nutrients, carbs or proteins, as you do with sucrose during your optogenetic stimulation or inhibition studies.
Thank you, Caroline. We are working actively on the subject, and we suspect that it is the case. And the reason is that these cells, depending on where they are located throughout the gastrointestinal tract, they are communicating two things, at least two pieces of information from the chemical stimulus. One is it good or is it bad, right? Like the valence of, is it positive or is it negative, right? How does it feel? And two is the intensity of the stimulus, because imagine, like, for instance, in that cookie, there's a lot of sugar, right? But if you just take a little bit of water with a little bit of sweetener, the intensity will be less, right? And the brain needs to be aware of that information. And I think that one of the main answers in the future is going to be understanding how it is that the different regions of the gastrointestinal tract inform our emotions through these subliminal signals, because we're constantly driven by these subliminal sensations. Thank you for the question.
That's great. And then the next question came into the chat box, and I think, Rana, you've already addressed it, but maybe just for folks to hear. So there's a question about the amount of dietary intake of potassium in the African-American patients that were part of your trial.
If I remember correctly, I think they matched kind of what the average was in ERIC and other cohorts that we've looked at, and that's about half of the adequate intake level. It's about 2,400 milligrams of potassium a day. So not near where the 4,700 milligrams or what's recommended anyway.
So, and I had a follow-up question that probably came more on the vitamin D side. So, the vitamin D is quite interesting. There are a number of disease states where vitamin D has been investigated. And there have been some in vitro studies kind of investigating the various properties of vitamin D as a nutrient. And I'm curious as to, what role you think vitamin D potentially is playing here. And I was also just curious, given the direct correlation and the true benefit, as you mentioned already, of kind of exercise and activity, is whether or not vitamin D is just a biomarker here of how much time someone spends outdoors and exercising.
That's true. That's a possibility. So I think vitamin D can have several roles. It can, so vitamin D receptors, I think, are everywhere. And so it's been shown to affect insulin secretion, insulin sensitivity, inflammation, which is involved in diabetes. It can affect that as well. So I think it's probably a combination. Probably higher vitamin D levels are in people who are outdoors more and more active, but there's still some people who are active that have low vitamin D levels. And so I think that still needs to be teased out. So thanks.
Great. All right, I'm gonna go through another round of questions here for everyone. We have plenty of time, and I think lots of good questions coming into the Q&A. So one question to Dr. Zimmerman. So you talked about the ABC Science Collaborative. I think this is like affecting so many people right now. And I think it's really, really important work. You know, we've seen universities, and most of the press that we hear right now is around universities opening and some of the differences in how universities have opened. And I guess generally I would view universities as very different to, you know, schools, primary schools, middle and high school. And you had mentioned in one of your slides kind of the role of testing. And what is the reality of the role of testing when you're talking about, you know, 5, 6, 7, 8, 9-year-olds versus college students? And do you think that's going to be a critical component to reopening public schools?
It's a really good question. I really hope it's not a critical component to opening public schools because it's quite an expensive endeavor. I mean, I think we're all pretty familiar with what Duke has done and what a wonderful job they've done in keeping the infection rates down. But the differences between like primary school and college are that hopefully, at least not on campuses, we're not having, you know, frat parties and we're not congregating and we're not living in dorms. So I would say in some ways it's much more of a bubble type situation on college campuses as opposed to people who were going in and out of the community or in and out of schools who were going back to the community. And so I think, you know, we know that practicing the 3 W's is effective. And so if we can do that and move towards doing that on a consistent basis, then I think, you know, we don't necessarily need testing. I think it can be useful in some certain situations, but it should not be the go-to in my opinion.
That's great and really good to hear. All right, so next up, Dr. Bojorquez, a question from Dr. Bryce Weinberg. So does your research relate to cancer cachexia, anorexia nervosa, hyperphagia with glucocorticoid therapy? Any correlations here?
Yes, thank you, Bryce, for the question. And because of time, I'm going to combine it with a question from Aidan McGuinness, too, who says that pharmacologically blocking the neuropod cell glucose detection pathway would reduce palatable food intake over the long term. And I think that both questions are related. And the reason is that depending on the intensity of the blockade, one could suspect, of course we have not done it yet, but one could suspect that over time, you will feel less stimulated and less good, so to speak, about a certain food, like calorie-dense foods. And then you can retrain that habit over time, because one of the most potent reinforcers of the food that we eat, if not the most potent, is the actual detection of the nutritional value. And let me put it the same answer in another way. We use all of the senses in our cephalic senses, our eyes, our ear, our nose, taste, to be able to find the food. But then it is up to the gut to be able to determine if the food that we found and we put inside of our mouths, that's why we say, like, trust your gut, right? Like, to be able to make sense if that food was actually valuable, because if it's not valuable, then you shouldn't spend a lot of energy trying to find it. And if we're able to modulate the sensory function, eventually our innate desire to find that food could be retrained. Thank you.
Great. All right, and then we have our last question, and if more come in, we're happy to take them. We do have some time, but this is for Dr. Chatterjee, and we have 2 here, so I'm going to read them both to you, Dr. Chatterjee. So the first one is, does the fact that many diabetic patients have comorbidities, specifically cardiovascular disease, hypertension, and the use of diuretics that are not potassium sparing interfere in any way with how you account for potassium levels in your study? And then there's a follow-up that also was, do you have any advice providing to patients regarding specific foods that would increase potassium and vitamin D levels?
Great, thanks for the questions. So for the first question, when I talked about the indirect associations between potassium and diabetes risk, that was really studied in the context of thiazide diuretics. And so they did find that in clinical trials that used thiazide diuretics, you know, potassium levels were lower and glucose levels were higher. So I think that does definitely contribute. And so I would say, especially in those people, we want to keep potassium levels up and high, or at least high normal. So that's one thing. And then as far as foods, yes, I can talk about potassium foods all the time. Unfortunately, for vitamin D, I think fatty fish is kind of the main source, but it's hard to get, you know, the recommended daily allowance is like 600 for most adults, 800 and 70 and older. But I think it's really recommended that people take it in some form of supplement to make sure they get enough in it. Potassium's hard to get the adequate intake level, and my kids are tired of hearing about it, but I make them eat leafy greens like tomato juice, tomato sauce, beans. It's not the typical bananas and orange juice, which have some, but they don't have enough to get you to the adequate intake level. Potatoes with the skins on, even though potato seems kind of counterintuitive to the whole diabetes thing, that's a good source of potassium. So.
Fantastic. Great. Thank you for that. So I would again like to thank our speakers, and Dr. Klopman here says congratulations to all of you. Fantastic presentations and really wonderful work. And again, thank you all for joining. I think this has been a great week so far. Please continue to join all of the week's events, and you know that you can get to the complete schedule on medschool.duke.edu/researchweek. Please, I think you will receive some surveys around feedback for this. I do think it's critically important at the end of the week that you let us know how this went, the concept of a research week versus a day, and any feedback that we can apply to next year, which I am going to be confident will be in person. And again, thanks to all of you for joining. Take care. We wish you and your families good health and wellness.